Hi, everybody. This is Rajam Roos, SEO and founder of the San Diego Pain Summit. And I'm here with Jarod Hall, who has agreed to give us some of his time today and talk a little bit about pain and what we should know about pain. But first, I just want to give a little bit of his background. And Jarod Hall is a doctor of physical therapy in Fort Worth, Texas. His clinical focus is orthopedics with an emphasis on the implementation of the current science of pain to aid in the management of both chronic pain and acute injuries. In addition, Jarod developed and leads both an orthopedic board specialty examination preparatory course through OPTIM manual therapy and fellowship, as well as a virtual mentorship with modern pain care for practicing physical therapists seeking to further their clinical expertise. He's also the author of the clinical resource text, Sticks and Stone, a collection of analogies and stories to better understand pain. So welcome, Jarod. Thanks again for joining us. And I was curious about, we were talking earlier and you talked about there's 9 things that you think everybody, regardless if you're a clinician or a person or whoever, should know about pain. Do you want to start off with number 1?
Sure. First I wanted to say just thank you for having me on. I appreciate the invite, and of course, I'm always willing to talk about all things pain because it's something that I think people should know a lot more about. We were talking earlier that I had kind of put together a list of 9 things that I felt like all people, clinicians and non-clinicians, should know about pain. And the reason for that is we kind of have a pain epidemic going on. We have steadily increasing rates of chronic pain across the nation and across the world. And, that's a heavy burden on our medical system. It's a heavy burden on the people experiencing pain. It's a heavy burden on our economy. And I'm trying to transition some of my thought processes from the micro level to the macro level. And instead of thinking about just the individual person in front of me, I started thinking if we could educate all of society about pain, clinicians and patients, people alike, then we would probably get a lot further, a lot faster.
I kind of, just sorry to interrupt, I kind of feel like that way as well. So, because we can educate, we can change how clinicians are educated. And of course, we can somehow change how lobbyists can change healthcare system. But really, if you can start educating the public about pain and they're going to start requesting better care, that can actually produce that change, in the rest of the system.
Absolutely. I think that, in my mind, it might be, hopeful optimism that there will come a tipping point at some time in which enough people know enough about the complexity of pain that we start thinking about it a little bit differently, stop thinking about the human body as a machine, and we stop thinking that there's a one-to-one direct relationship between the experience of pain and the occurrence or the degree of tissue damage and that sort of thing. And we'll definitely get into that in, the 9 things that I think people should know about pain.
Yeah, don't give them away now.
So I guess one of the most powerful things, and it's the reason that I wanted to put it as number 1, fact number 1 that I think people should know is that your pain is real. A lot of times people are experiencing pain and they go and they get imaging, or they go and they get, examined by some sort of medical provider, and the medical provider can't really explain to them, why they're having pain. Nothing is broken, nothing is torn. You didn't have this injury, or that surgery or that injury should have been healed. We fixed X, Y, or Z. And people hear the message that this person thinks that it's all in my head. This person thinks that I'm making it up. This person thinks that I'm malingering or faking it. But the truth of the matter is, even if somebody can't find a tissue reason for your pain is always real. And I was just reading a study that was published a couple of days ago that was a systematic review of a whole bunch of studies that had asked people about their pain and kind of how they felt after their medical encounters. And by and large part, several people reported they didn't feel heard, they didn't feel believed, they felt like people were treating them like they were making up the fact that they had pain, and they didn't feel understood. So that's why I think that one of the most important things that we can tell everybody, or somebody can think to themselves, is my pain is absolutely real, even if it doesn't seem to make sense to this medical provider in front of me. And don't let anybody tell you that your pain isn't real, because nobody else knows what you're feeling. Only you have the ability to know what you're feeling.
And so just to speak to that, for those patients that come see a clinician and say, I know in many cases people actually aren't listened to, in particular, women and people of color. But what about the clinicians who are listening, but maybe are trying to educate them in a way that still makes them feel like they're not being heard? Do you think if you say from the get-go your pain is real, that would help? So if you want to, what would you recommend to start out with if somebody wants to talk about pain with their patients, but yet still, because you have to be so careful with your wording, and you can even not even say anything about the brain, but yet that's the takeaway the patient will get.
Yeah, so this is one of the most delicate situations that we deal with in healthcare as providers who work with people in pain. And what I always say, and of course it's not me that came up with this, any really great clinician knows that the first thing that you should do is shut your mouth and open up your ears and listen to that person and hear their full story. And we know that on average, depending on what study you look at, patients get interrupted between 11 and 18 seconds after they start talking. And we also know that if you actually just let somebody talk uninterrupted, on average, they will feel like they've told their story within 90 seconds. So it's not a time issue. There could be an outlier, somebody that really wants to talk for 5 or 10 or 15 minutes, but most people will get their story out in 90 seconds and feel like, okay, I've told this person where I'm at. And I think that you have to have a little bit of empathy as well as a little bit of humility and say, I haven't dealt with exactly what you're dealing with. It sounds like that is really difficult. I don't know exactly how you feel, but what I do know is that I want to try everything that I can to help you feel better and to help you have less disability and to help you move better and have more confidence. And, I can't promise you that I can just wave a magic wand and fix you right now. But if we, engage in this together and work together, and you keep an open line of communication with me, let me know what you're feeling and how you're responding to certain things, we can develop a program that's really unique and tailored to you to help you work through this process. And then from there, maybe over the course of another couple of visits or maybe even over the course of a few weeks or a few months, there could be little opportunities that open up to talk about the complexity of pain. There might be an opportunity to talk about the impact of sleep. There might be an opportunity to talk about the impact of stress. There might be an opportunity to talk about metabolic factors and systemic inflammation contributors to somebody's experience of pain. And I think we get in a habit, those of us who have gone down the rabbit hole of reading a tremendous amount about pain and learning about it, that we just want to word vomit this stuff back all over people because we find it so cool. It's so interesting. It's blowing our minds. It's completely different than what most of us learned in school. So we kind of come at people with that same vigor and zeal that we feel within ourselves. And that can be a little bit suffocating for somebody that's not ready to hear it just quite yet.
Yeah, that's a good point. And just to touch on that real quick before we move on to the second one, that reminds me of another discussion I had with a pain patient who's become a clinician, Amy Eicher, and she was saying how when it was the first clinician that she went to, the diagnosis they gave her was the one she respected the most. And that was, your pelvis is out of whack, your ligaments are tore, everything needs to be balanced and strengthened. So that was what she believed. And if she went to a clinician who didn't confirm that, she automatically didn't believe them. So if she was going to go to somebody who would try and spout out this pain education, she would just automatically think they didn't know what they're talking about because it didn't match what they were being told. So, to what you're saying about hearing the patient's story, it's probably helpful to find out what they've been told about their, pain from other professionals, I think.
Oh yeah, I have put my foot in my mouth so many times trying to stick the cart in front of the horse and talk to people about stuff that they just weren't quite ready to hear yet or didn't really want to engage in that discussion. So now one of the things that I do is I try to ask people's permission to talk about something else and say, would it be all right with you if we talked a little bit more about how this stuff can be, different than what you've heard before, or can we talk about a different perspective on things that I might be contributing to the pain that you're feeling. And if you have somebody's permission, if you have their okay to talk about things, all of a sudden they've backed down, they've opened up a little bit, they've let you step into their world versus you trying to beat down the door with all your cool knowledge that you learned in that research paper you read last weekend.
Great.
Yeah. I guess, so I don't talk your ear off all day long, we'll move on to number 2. And the second fact that I felt like it was really important for everybody to have a grasp on is the fact that pain is an experience and not just a sensation. And that might sound a little bit complex at first, but we know that the sensory aspect of a lot of pain experiences is, of course, nociception. And we know that nociception conveys chemical danger or mechanical danger or thermal danger. But when that information hits the brain and the person experiencing or receiving that information interprets it, it can go a lot of different directions, and that the very same stimulus can be felt and emerge in a very different way. If we're purely talking about cases of nociception without getting into the weeds of the experience of pain and the absence of nociception and things like that. So I like to think about pain almost like, or nociception almost like a house, and it is the wood, the studs, the nails, the screws, the shingles and the tiles. It is the hard stuff. It's the sensory information. But the experience of pain is a lot like a home. It is the history, the emotions attached to it, the experiences, the smell, the memories, the people that you surround yourself. So just a bunch of sticks piled together might be a house, but it doesn't feel like your home. You don't feel a certain way when you live within it. You don't feel a certain way when you get home to it. It doesn't have the same impact as an actual experience, right? So the experience of pain is so much more than just the sensory information that comes in, because what you believe about that sensory information, what you believe about the situation that you're in, the context, whether it's a scary context or not a scary context, whether you're having fun or not having fun, whether you're a little bit stressed out, whether you're sleep deprived, or whether you're a little bit hungry or a little bit anxious, all of these things can influence the way that you interpret that sensory information coming in, and either wind up that sensory information to make you have a greater experience of pain, or wind down that sensory information to make you have a lesser experience of pain. So we need to realize that there's 2 totally different aspects to pain, and some of that is sensory, but some of that is also emotional, and together they lead to the experience of pain that one actually feels.
And so how would you, so when you're explaining that here, I completely understand what you're saying. How would you, is that how you would explain it to a patient who is coming in, or how would you explain the difference between pain being an experience and sensory to somebody who doesn't really know what that means?
So there's a lot of different ways that I've tried to explain this to people. I've literally pulled up the rubber hand experiment in clinic just to show people some really cool neuroscience, and we laugh about it and they're like, whoa, I don't understand. How could somebody feel that rubber hand being whacked with a hammer? And there's another really cool experiment called the fire and ice experiment, where people are blindfolded and they're told that they're going to have a match put on their arm. The guy lights the match in front of them, he blows it out, they smell the match, and then while they're blindfolded, he pulls out a piece of ice and sticks it on their arm. And the people scream and jump back and they're like, oh my God, I can't believe you actually burned me. Because the context in which they got that sensory information made them expect to be burned. And of course, the whole ability to integrate a rubber hand based on visual and tactile information over time, that kind of sensory integration that the brain can take on a new object that's represented in your peripersonal space and claim it as its own is just a mind-blowing thing. So I've gone so far as to show people videos like that. In other scenarios, I might just tell a story. It's like, hey, have you ever, imagine yourself right now walking through the woods on a bright sunny day, and it's wonderful, and you're with your friends. It's absolutely beautiful. You smell the pine trees, you smell like the dew on the ground, and your friend reaches up and grabs you on the shoulder. How would you feel? No problem. I would feel okay. I'm having a great time in this beautiful environment with my friend. I say, okay, now imagine yourself in those woods, but it's nighttime. It's cold outside. It's wet and damp. You're alone. Your friend's not with you anymore. You hear a wolf howl. You see a full moon. You just walk through a spider web and then something touches you on the back of the shoulder. How would you respond to that?
Oh, that's a good one.
So they start to grasp that, you know what? All of these contextual influences can totally change the way I would respond to some sort of sensory information. And I say, pain isn't always like that. I believe that you've probably had an injury going on. And, I believe that you probably have some sensitivity there, and maybe your tissues aren't as resilient as they once were. But hey, that's what you're here to work on. But I also want you to recognize that there's other things that influence the way that you experience this sensory information. And, if you recognize that, that can help you be a little bit less scared of your pain and a little bit more confident pushing into it, because it doesn't necessarily mean that you're hurt or you're damaged.
I like that description. And for those who aren't familiar with the rubber hand experiment, we'll put a link to that on the page of this talk as well.
All right. So I guess if we're going to go on to number 3 out of 9, pain does not equal tissue damage. And we've already been talking about this a lot. We've been talking about the context and the sensory information, but most people have the idea that the human body functions like a machine, and that we should experience pain anytime there's tissue damage, and we should experience a 1-to-1 ratio between the amount of tissue damage you have and the amount of pain you have. And the easiest example of this is you ask somebody, hey man, have you ever had a paper cut? They're like, yeah, those things hurt really bad. It's like, yeah. Is there a lot of tissue damage there? No, there's not a ton. Have you ever squeezed lemon juice in your paper cut? And they're like, yeah, that's the worst thing ever. And I'm like, did you cause any more tissue damage with that lemon juice? They're like, no, it's just lemon juice. It's benign. I love to drink lemon juice. It's not toxic. It's not bad. And I say, a lot of this pain is about sensitivity. And lemon juice will cause sensitivity in that cut. It's not causing any more tissue damage, but what it's doing is activating some receptors that send some messages to your brain that say, hey, I'm being really sensitive right now. And you're not super worried about your injury getting way worse if you get some lemon juice in your paper cut, just like you shouldn't be worried about your knee degenerating more if you feel a little bit of discomfort when you squat or go up and down stairs. If you gradually expose yourself to that, you can decrease that sensitivity, just like if you gradually expose yourself to working with your hands in the garden, you would build some calluses, your hands would get less sensitive, and you'd be able to work longer and harder in the garden without any issues. So I try to weave a lot of stories in to help people
I can hear that.
get a better grasp on pain. I tried the whole just tell people black and white information, tell people about research and all of that and what I learned at this course past weekend. they're just not receptive to that very often. Of course, you have some people that have a science background or they're just very inquisitive and they love it, but most people really enjoy stories. Most people really enjoy anecdotes, and most people enjoy like a lighthearted, nonchalant type of conversation rather than let me lecture some stuff at you and let me tell you about X, Y, and Z. Like, no, let's talk about this in an abstract manner that will help you draw some connections between what you're experiencing and other, experiences in life.
Cool. Number 4.
Number 4. We're kind of going on a theme here that we've already talked about a little bit. Pain is way more complex than we ever imagined, right? So if we go back to Rene Descartes, pain was you stick your toe in the fire and you have some information carried up some levers and pulleys in the body that got to your little tiny pea brain, or your what he thought was your pineal gland, right, which was the center of all emotion and the center of human cognition, to the gate control theory of pain, to the neuromatrix theory of pain, to this biopsychosocial construct and some newer thoughts of predictive processing and the emergence of the experience of pain. All this is mumbo jumbo, right? Who cares? It's really complex. It's way more complex than we ever thought. Pain isn't just that sensation. It has the ability to be influenced by countless factors, from your genetics to low-grade neural inflammation caused by maybe, dysregulated metabolism or an unhealthy diet, or maybe you're chronically sleep deprived and your body isn't healing the way that it needs to, and maybe that chronic sleep deprivation is leading to an increased sensitivity in the nerve endings in your body. Maybe it's leading to a buildup of some proteins in your brain that make it not function quite as normally as it should. Maybe it's all about the fact that, you don't have great movement variability. You stay stuck in the same rigid, repetitive motions all the time. You never break out and do anything different with your body, and it gets essentially tired of doing the same things over and over again and fights back through getting a little bit sensitive, screaming for some more motion, some more, fun in your life. And this isn't even to talk about the social, cultural, and emotional aspect of how, your different cultural influences and how your family raised you and the culture that you live in has taught you to think and feel about pain, and not even getting into how anxiety or a history of depression may influence your experience of pain. So what we know is that there's just so many aspects of the human being that have to be taken into account when you're looking at any person's experience of pain at any point in time. And it's not just where they are at this singular moment in time. You have to look at their past, and you have to look at their family, and you have to look at their culture, and you have to look at their expectations, and you have to look at their biology as well, and you have to look at their mechanics and their biomechanics and their tissue health. And it's this multifactorial complex experience rather than just a one-to-one sensory input from the body.
And so, yeah, even these 9 things that we should know about pain just scratches the surface. They're just things that we know right now.
Yeah. If you can't tell, I like to ramble, so I can talk about this stuff forever and not even scratch the surface. And this is just me, who doesn't even know a fraction as much as other people out there, and really, really, really well-educated people in the experience of pain. So I don't even know what I don't know yet, and I'm already overwhelmed with how complex it is.
When you were describing all the aspects of pain, I was imagining a sandwich being built. Who is that comic, Dagworth, that built the really big sandwiches? Anyway, sorry.
It would be a huge sandwich. Okay, so if we're going to go to the next aspect, number 5, if you haven't picked up on this yet, it's been an underlying theme. Words have the power to make a person's pain better or to make a person's pain worse. And the most hallmark study on this is Ben Darlow's 2013 study, The Enduring Impact of What Clinicians Say to Their Patients. And then his follow-up study in 2015, Easy to Harm, Hard to Heal.
Can you send me links to those, and I'll also put them on this page for anyone watching can look at those.
Absolutely. And what we found out is that because pain is this complex experience that has to do with not only sensory information, but the context in which you experience it and all your beliefs and your expectations, when somebody tells you something really negative about your body, like say, it's torn, it's degenerated, it's worn out, it's all this wear and tear, you're unstable, you're out of alignment, you're X, Y, and Z. Some people, not everybody, but some people will really latch onto those words, and those words will create a little bit of anxiety within them. They'll create a little bit of what we call maladaptive beliefs, and they might create a little bit of fear avoidance behaviors. So thinking negatively about your body, and because of those thoughts, reducing the amount of activity that you engage in. And if you increase a little bit of anxiety or a little bit of fear or worry, we know that that can actually influence your experience of pain and drive up the intensity of your pain just a little bit and how much it affects you. We also know that movement tends to be very healthy for people, and it helps to reduce pain. So if you have fear avoidance beliefs about your body and you're scared to engage in movement, people tend to reduce how much they move, reduce the variability in which they move. They tend to socially withdraw and not get out and do as many things. Maybe they don't engage in that exercise activity or that social movement activity that they had before. And this starts to affect you on a biological level as well, because maybe your tissues aren't as strong anymore, or maybe you're not as metabolically healthy as you were before. And our bodies, a lot of ways, function in really interesting feedback loops, where if you're moving very little, they will become more sensitive to movement. So as you move less, your body becomes more sensitive to movement, and that increased sensitivity to movement actually leads to a greater amount of sensory information to the brain that's perceived as fearful or threatening, and a bigger experience of pain. So you can slowly work yourself down a spiral of less movement, more pain, less movement, more pain. And that can all come from a few simple words that somebody told you.
What would you say to those clinicians? So I think it's easy for us to think, of course, we have our biases. We tend to think we're better than we are. What's the recommendation you would give to clinicians to find out if they're using negative language with their patients?
So that's a really good question. There was a recent editorial published in the Journal of Orthopedic and Sports Physical Therapy by Mike Stewart called Sticks and Stones. And it is all about this concept of words that you are and aren't using. And what they did was give a list of words and examples of phrases that could be potentially threatening or harmful, or what we call leading to iatrogenic effects, or leading to a nocebo effect in the patients. And they gave a list of words and phrases that were replacements for, so things that would be maybe less threatening. And we can give a link to that study. I can send it to you as well.
Yeah, that'd be great.
So I think just exposing yourself to the ideas, like, I never thought about the fact that that could be not the best terminology or not the best phrase, because we get in the habit as medical professionals of saying, well, this is what I learned, this is what we call this. We call it spinal instability, or we call it disc degeneration, or whatever it may be. But interchanging, disc degeneration with a little bit of tissue sensitivity, or an irritated disc, or an aggravated ligament, changes the perception from something that's permanent and enduring to something that is temporary and can be gotten past pretty easy. And what I do is I challenge the people that I work with, my other therapists in my clinic, the techs that I work with, to check my language. And if they hear me say something, next time, call me into the other room, or when we're in the kitchen or in the break rooms, like, hey man, I heard you say X, Y, and Z earlier. you were in your explanation zone, and I didn't want to influence, the respect or the rapport that you had with your patient, but I wanted to let you know that you should probably check that language just a little bit or try saying something different. So we have an accountability system in my clinic where we do that.
You do that to each other, or do you think that by them looking out for you, do you think that makes them more aware of what they're saying as well?
Both. It's bidirectional. The more that you start focusing on it, the more that you hear those things, and the more you start thinking about what you're saying. Because in reality, we know that education is a really useful intervention for people, which means that your words are an intervention. And it means that your words have the power to harm people and be a negative intervention. So when you start thinking about dosing your words and choosing the right intervention at the right time for the right person, there's an increased respect for what you say, and you slow down a little bit and you try to make sure that you're not inducing harm with what you say to somebody, because of course the first rule in medicine is to do no harm.
That's great.
And we're moving on to number 6.
I know I want to keep talking, but I want to have time to do I want to have time to do all 9. So
like I said, just tell me to shut up. I talk way too much. Number 6 piggybacks off of number 5. And in the same way that words have the power to make pain better or worse, diagnostic imaging has the power to make a person's pain better or to make a person's pain worse. And we have done enough studies now that we see when somebody gets a really negative imaging study, or they get the same exact imaging study read to them in a negative manner, it actually influences the amount of pain that they report, and it influences the amount of disability that they experience, and it influences the amount of care they end up seeking and medical expenditures they end up using. So we know now that there are a lot of quote unquote wrinkles on the inside, that if we scan people over the course of their life and we take huge populations and we look inside them like we've never been able to do before, that we see the same changes on people that do and do not have pain. And if we take those images and we take them to a third party surgeon or radiologist and we throw them up on the screen and we say, hey, look at this image and tell me who has pain, we know that they're no better than a coin toss at saying this person does or does not have pain. And that's not really great odds from looking at an image and determining if somebody is or is not in pain, which tells us that imaging findings, while they can be tremendously helpful in certain scenarios, also have the power to be very harmful in certain scenarios and should be interpreted with care, and they should be conveyed to patients with care.
So just to touch on that, what would you say to a patient who comes into your office and they have their, thing in hand, and someone else has pointed out their degenerative disc and they're really concerned about it? What would you recommend that clinicians can do to kind of walk them back from that ledge without putting them on the defensive that you're saying their pain isn't real?
This is one of the other hardest things to do in the clinic. A lot of times I like to ask people, especially if they just started having pain a month ago or 3 months ago or even 6 months ago, whatever it is like, hey, before you started having this back pain or this knee pain or whatever it was, how were you doing? They're like, yeah, I was doing pretty good. I was playing golf, or I was walking up and down stairs and so on and so forth. And I say, well, these degenerative changes, they take a really long time to kind of build up in somebody's body. Do you think that you were rocking along just fine one day and then you woke up the next day and all of a sudden your joint was degenerated, or all of a sudden your discs were desiccated or whatever it was? Or do you think that maybe that stuff had been there and you were going along just fine, you had no problems, and maybe something happened in life, maybe you overworked it a little bit, maybe you over twisted or torqued just a touch, maybe you were going through a really stressful period in your life and you were kind of run down and this cropped up, and if you were doing just fine before this cropped up, don't you think you can probably get back to doing just fine again, even though you have these changes? And sometimes that works really well for people, and sometimes they're just not quite ready to hear that yet. And we go about our business and I don't bring it up again. And I just try to prove to them through exercise, through manual therapy, whatever it may be, that their pain is modifiable, that we can make it feel better with certain things. And if we can make your pain feel better, then it must not be 100% attributed to whatever imaging finding that you have, because it's variable. If the imaging finding doesn't change, but your pain does, maybe your pain isn't 100% dependent on that imaging finding.
And that seems to be a common thread with the other people who have participated in this event, such as Mike Stewart, some others. It seems to be almost kind of what everyone tends to say. And I thought Greg Lehman at the 2018 summit, somebody asked him about that, and he said, he says, I say, yes, and let's go see what we can do, you know, as far as movement. Like he's just like, yes, and, you know, so yeah, I think those are good because I think that's a really common question that a lot of clinicians have, like, well, then how do I do that? So I think that's really helpful.
Yeah, and then maybe once a person is kind of feeling it a little bit, they're like, all right, this Jarod dude, he's making sense. Like, maybe this isn't 100% about my joint finding or whatever it is. Then I say, hey, would you like to see some really cool stuff? Like, I have this research study back in my office that I think you'd find really interesting about imaging findings. And they're like, yeah, that sounds pretty cool. And I have this big poster printed out that's like, how many people without pain have these findings on imaging? And once they're already like into it and they've taken, I don't want to say taken the bait, but they've bought into this idea. They've bought into this idea of, you know what, maybe it's not 100% about my imaging finding. I want to let them know that they're normal. I want to let them know that there's nothing wrong with them and that they're just like all of the other people in their age range and in their cohort and in their demographic that normalizes their imaging findings, and it also normalizes their pain. Because what we don't want to do is make pain this terrible beast. You know, we don't want to demonize pain, because if you're alive, if you're a human being, you will have pain. And in most cases, a ton of cases, it's a great thing to have. It lets you know you need to do something different. And it's the isolated cases of long-term persistent pain that don't make a lot of sense as far as tissue healing and all that sort of stuff, in which maybe it's maladaptive at that point, or maybe it doesn't make a lot of sense for that person to feel it at that point. But we want to let people know that it's okay and not be afraid of having a little bit of pain. So, you know, I try to dovetail into that conversation just a little bit as people are ready. I'm certainly not having that conversation with every single person that walks through the door, just because if you're trying to force information down people's throat, you're going to encounter the backfire effect and you're going to lose people. And that's not what I'm trying to do.
Cool.
I guess we can move on to number 7.
I know, I'm trying to.
So we don't run out of time.
Yeah.
Number 7, I already alluded to this earlier. Movement can be among the most powerful ways to actually improve your pain. So a lot of people, because they think pain is about something is broken or torn, automatically have the thought, I probably shouldn't move, because if something is broken, ripped, or torn, movement will probably break, rip, or tear it worse. But all of the evidence shows movement is pretty good for pain. It improves tissue loading capacity. It decreases sensitivity. It makes you metabolically healthier. It releases endogenous opioids. It causes, descending modulation of upcoming sensory information to the brain. It causes all these really good things to happen. And showing people that they can move and empowering them to move and have the internal locus of control, that they can take an exercise or a stretch or a weightlifting event or a cardiovascular exercise and make their pain better, that's super empowering. And it proves to them that their body is strong, and it gives them the tools to move forward managing themselves, which is ultimately what we want to do, is empower people to take control of their situation and be able to modify what they're feeling or the activity that they're doing confidently and know that they're not broken and have, resources to do that. So if everybody in the world could know that movement on average is really good for pain, I think that that would be a tremendous breakthrough, because instead of sitting on the couch when you hurt and getting less healthy and getting more sensitive, people might gradually engage more and desensitize themselves and stay healthy and work through a lot of the pain that they have.
Yeah, from my anecdotal perspective, in my 20s, I did a lot of walking. A lot of walking. And now if I don't get in like a hike or a walk at least a couple times a week, I start getting really bad Charlie horse cramps at night. And so they'll tell me, I need a walk. And then I'll go on a walk or a hike or something. And then also, because my job now consists of a lot of sitting, I've noticed pain in my sits bones if I'm not doing my walks and hikes. But then once I do those, it just goes away. But if I let it go a week or two without any walking or hiking, yeah, it's pretty funny. And I know that's not the same for everybody, right? Not everybody can do like the type of hiking that I do, but it's just funny how that's like, okay, well, there's my medicine.
There's no denying that we were made to move and that we're really adaptable and that we improve when we move on a biological level, on a physiologic level. So if we could have everybody really embody that, point number 7, that movement can be good for pain, it would change the game. It would prevent a lot of medicine, a lot of surgery that's unnecessary.
And just real quick, what would you say to a clinician who has a patient who comes in and they're very, very scared to move at all? What are some things that they can do to maybe encourage a little bit movement from the patient?
Ask every question you can about trying to find something that they enjoy, right? If a person enjoys a certain activity, whether it be dancing or whether it be walking or whether it be, like, we have a guy in clinic
washing the dishes.
washing the dishes. We have a guy in clinic right now who has had multiple lumbar surgeries, is really discouraged with himself because he's put on a lot of weight. He continues to have back pain. This is long term. But when he was younger, he loved Tai Chi. That was one of his favorite things to do. So we break it out the Swiss ball and have him, he's doing Tai Chi on the Swiss ball because he really enjoys that. And that's a way to start engaging movement and say, hey, I noticed that your back doesn't seem like it's hurting so much when you're doing this Tai Chi. What do you think about that? And starting to ask those reflective questions once somebody is engaging in some movement that doesn't appear to be as bad as they had anticipated it would be. And then when they start asking the questions to themselves and coming to their own conclusions, that's when you make a ton of progress, rather than, again, just telling somebody, well, movement is good for you. I know that you hurt, but if you just move, it'll be great. That doesn't usually go over, that doesn't go over very well. Like, here's these 17 super complicated exercises that you have no interest in doing. These will make you better. That doesn't tend to go very well. And I've learned a tremendous amount from, other clinicians, especially Ben Cormack, about trying to make exercise a little bit more fun, trying to put the fun back in, medical exercise and stop over medicalizing it and making it dry and boring. And it's changed my practice a ton, because when you see people smiling and forgetting that they're there because they hurt, you're making a big impact on their life.
That's beautiful.
And then if we move on to point number 8, fact number 8, this is a simple one. It is stolen from, I think, whether it's NOI or ISPI or whoever those guys are, no pain, no gain, with a KN, right? The more that you know about pain, the more gain that you can get. And that's not to say that simply knowing about pain, reading about pain or having somebody explain pain to you will improve your pain, but it's to say that if you recognize how complex this experience of pain is and how many factors go into this experience of pain, then it will change your perspectives on what it is to experience pain, which might change your willingness to engage in activity, which might change your level of disability, which might change the psychosocial factors like stress and anxiety that you have because you're missing out on your valued activities, which might just turn out to reduce your pain down the road as well. So if all of society knew more about pain, all of society would see, in my opinion, and in some of the research, would see tremendous gains in reductions in disability, reductions in pain, reductions in opioid addictions and unnecessary prescriptions, and reductions in surgeries, and reduction in the tremendous amount that we spend every year on helping people with persistent pain, which is, by last estimate, over $600 billion a year is the direct and indirect cost of managing persistent pain in the United States, which is kind of mind-blowing when you recognize that that's more than cancer, diabetes, and metabolic, or cancer, heart disease, and metabolic syndrome all put together. And then last but not least, number 9, even if you do have persistent pain, even if you do deal with some aches and some pains and long-term back pain, long-term knee or neck pain, you can still live well with persistent pain. And I think this goes back to a lot of the other facts about pain, knowing that movement is good, knowing more about pain, knowing that pain and tissue damage are not the same thing. If you recognize these things, you can still have a very fulfilled life, even though you have pain. And this was taken from a recent study published by Bronnie Lennox Thompson called Living Well with Chronic Pain. And it really spoke to me because we do focus so much on just reducing people's pain. Pain. The second they walk in, it's asking about their pain. After we do an exercise, it's asking about their pain. After we do some soft tissue work, it's asking about their pain. When they leave, we're asking about their pain. We're asking about how they felt when they woke up the next morning. And all we do is focus on their pain. So what do? They focus on their pain too. And we actually see that there are people that rate themselves, even though they have pretty significant long-term persistent pain, as being able to live a really good life and being able to engage in their valued activities, being able to reach their goals, despite that they have pain. And what by and large part seems to be a big factor about that is having strong self-efficacy, having some internal locus of control that they believe they have the ability to modify their pain or to make changes to their lifestyle in a way that doesn't impact them too negatively, and continue doing what they'd like to do. And knowing more about this whole complex experience and how to, make modifications to their sleep schedule or their activity schedule to allow them to do the things they want to do. You can still have a great life that is very fulfilled, even though you do have long-term persistent pain that you deal with.
Yeah, Dr. Kevin Val spoke at the 2017 summit, and he brought up research showing that the more we spend fighting our pain, the stronger the perception of pain becomes. And so that was very interesting.
I mean, absolutely. What's more threatening? Something that you're constantly thinking about and fighting and that's bearing down on you, or something that you say, nah, I'm not so worried about you anymore. I'm going to try to engage in the things that I love, and I'm going to, give you a cold shoulder a little bit. The more that you think about it, the bigger it becomes. And then we can talk about the neuroscience behind that and, the amount of connections that you might have in your brain, and the stronger you can make a neurotag regarding that experience of pain. But that's going down a whole path of neuroscience that I'm not smart enough to talk about.
So that was the 9. I'm glad we had time to go through all the 9 steps, because each of those is a great conversation. What's something before we leave today that from this discussion, from sharing these 9 steps, that anyone who's listening, whether they're going back to work after their break or tomorrow morning or Monday, what is something they can take with them that they can start doing right now that's based on this information, the 9 steps of knowing what pain is?
So are we talking about clinicians or are we talking about people in general?
Probably clinicians, because that's who's the main audience of this is clinicians. So I'm going to guess, but you can do both. How about one of each, just in case somebody's watching it for the have fun of it.
Okay. Am I allowed to curse at all? Is that off limits? Okay. Um, Put simply, for clinicians, I would challenge you to stop saying stupid shit. Really check your language. What you can do tomorrow when you walk into the clinic, what you can do after your lunch break right now when you go back into the clinic, is think about the words that you're saying to somebody and value them as an intervention the same way you value your favorite manual therapy technique, or the same way you value your exercise prescription abilities, or the same way you value your differential diagnosis. The words that are coming out of your mouth are so powerful. They have so much influence over what the person in front of you thinks about themselves and how they feel about their body. So try to replace words that sound permanent with words that sound transient. Try to exchange ripped and torn for irritated and aggravated. Try to, replace degeneration with, you know, overworked or underprepared, not as resilient or robust as we're going to make that joint or that tissue or whatever it is. If we can start to convey an idea of the transientness of a person's condition rather than the permanence, that automatically flips the perspective that a person has on their ability to get better. And we know by and large part across multiple studies that one of the biggest predictors of a positive outcome with rehab is a person's belief that they will have the capacity to get better. We know that people who don't believe that their shoulder will get better end up having shoulder surgery, and those people that do believe their shoulder will get better end up doing extremely well with rehab and not needing shoulder surgery or not deciding to have shoulder surgery. So think about everything that you say from that perspective. And then,
Don't say stupid shit.
yes, yeah. I didn't
I
know if
said
I was
don't
allowed to say.
say. Don't say.
And then if there happens to be a random non-clinician out there, I just want to let you know that we're trying so darn hard to improve what we do to help everybody recognize, ourselves, our colleagues, the public, that pain is complex and that we believe that you do have pain, and we believe that your pain is real. And we just want you to recognize that there's so many things that go into it, and we want to try to help you in multiple different avenues rather than just your strength or your range of motion or your alignment or your posture.
Great. Well, thank you again so much, Jarod, for joining us today. This is Jarod Hall, and we appreciate your time very much.
Thank you. I appreciate you having me on.
All right. Take care.